Okay, week 4 of Nursing 435, Maternal Child Nursing. Our objectives for this week are to assess the antepartum patient for the presence and severity of risk factors, develop a plan of care for the antepartum patient with a hypertensive disorder, differentiate among different antepartum hemorrhagic disorders, describe the major endocrine and metabolic disorders in the antepartum patient, and to analyze the effects of selected medical and surgical disorders on the antepartum patient. First, let's look at risk factors. There are biophysical risk factors, things that originate within the mother or fetus that affect the development or functioning of either one or both. There are some genetic considerations, genetic diseases, nutritional status of the mother, medical or obstetrical disorders that may be present in the mom or develop in the mom that can affect both mom and baby. Psychosocial factors include maternal behaviors and adverse lifestyles that have a negative effect on the health of the mother or fetus, such things as smoking, caffeine, alcohol, drugs, and her psychological status. If there's any kind of mental illness, including depression, that could be a problem for the developing fetus. Sociodemographic factors arise from the mother and her family that may place the mother and fetus at risk. Things like low income, which leads to a lack of prenatal care, the mother's age, as we've talked about, adolescents have a higher risk because of their developmental needs, and mature mothers have increased risk factors just by their age. The mother's parity, how many deliveries mom has had, her marital status, think about why that might be true, residence, where she lives, what kind of housing she might have, and her ethnicity. Certain ethnicities are predisposed to certain diseases that can manifest, such as hypertension or sickle cell disease. There are environmental factors that include hazards in the workplace and the woman's general environment, things like infections, radiation, chemicals, therapeutic and illicit drugs, industrial pollutants, cigarette smoke, stress, diet, and even paternal exposure to mutagenic agents in the workplace has been associated with an increased risk of miscarriage, which that's kind of a new finding. And that includes nurses working with chemotherapeutic drugs. The first type of disorder we're going to talk about today is hypertensive disorders. Classifications. The first one is gestational hypertension, which is the onset of hypertension without proteinuria after week 20 of pregnancy. Hypertension is defined as a systolic blood pressure greater than 140 millimeters of mercury systolic or diastolic blood pressure of greater than 90 millimeters of mercury. Should be reported on at least 2 separate occasions, at least 4 to 6 hours apart, and within 1 week period. So you don't base your diagnosis of gestational hypertension on one reading at one visit. The next hypertensive disorder is preeclampsia. It's a pregnancy-specific condition in which hypertension and proteinuria develop after 20 weeks of gestation in a previously normotensive woman. We don't know why this happens, but it most often happens in primogravid women or multiparous women with a new partner. There is an exception to that it can happen, preeclampsia can happen in molar pregnancies before 20 weeks. Most often, the gestational hypertension occurs in women younger than 19 or older than 40. It can be classified as mild or severe, and there are complications such as HELLP syndrome, which is hemolysis, elevated liver enzymes, and low platelet syndrome. It is a laboratory diagnosis versus a clinical diagnosis. It's rather ominous and can lead to complications such as hemorrhaging and death. And then there's eclampsia. excuse me, eclampsia is the onset of seizure activity or coma in a woman with preeclampsia without a history of pre-existing pathology. In other words, she had no she has no history of a seizure disorder or other pathology, brain tumors or what that might cause seizures. Can be tonic-clonic seizures, can occur before, during, or after birth, although 1/3 of them occur after, almost within the first 48 hours. I have had experiences one time when there was a woman that had a eclamptic seizure 2 weeks after delivery. The next hypertensive disorder is chronic hypertension, and it's hypertension present before the pregnancy or develops before 20 weeks of gestation. It's initially diagnosed during pregnancy and persists longer than 6 weeks postpartum, which indicates that there has to be a reevaluation at the 6-week postpartum checkup. Women with chronic hypertension have an increased risk of perinatal mortality, as you can imagine. Hypertension creates peripheral vasoconstriction, which includes problems for the baby because of decreased perfusion. The next disorder with hypertension is chronic hypertension with superimposed preeclampsia. Increases the morbidity for the mother and the fetus. Diagnosis is made with the following findings. Women with hypertension before 20 weeks gestation and new onset proteinuria, or women with both hypertension and proteinuria before 20 weeks gestation, there's a significant increase in hypertension plus one of the following: new onset of symptoms, thrombocytopenia, or elevated liver enzymes. That would give you the clue as far as preeclampsia and worsening preeclampsia. It's important to do a careful assessment on these women with hypertensive disorders. A history, including medical history, any history of preeclampsia in previous pregnancies, family history of hypertensive disorders, mom, dad, siblings, social history for marital status, cultural beliefs, activity level and lifestyle behaviors such as smoking, alcohol, and drug use, current symptoms, any headaches, epigastric pain, or visual disturbances such as blurred vision or seeing spots before their eyes. The physical exam includes blood pressure, an assessment for edema, deep tendon reflexes, and uterine tone and tenderness, presence of vaginal bleeding. Lab tests for this woman will be including hematocrit, platelet count, liver function, weekly 24-hour urine collection for protein, twice weekly urine dipstick for protein by the healthcare professional, and fetal testing. Daily fetal kit counts can start happening at about 32 weeks. Non-stress tests or biophysical profiles 1 to 2 times per week. Again, beginning about week 32. Antepartum hemorrhagic disorders. There are a few. Early pregnancy bleeding includes miscarriage or spontaneous abortion. You can have a threatened where there is cramping, maybe some bleeding, but the cervix is not open. Inevitable, there's cramping, bleeding, and the cervix is open. Incomplete, part of the products of conception have been expelled but not completely. And then a complete miscarriage where everything is gone, the placenta, the membranes, and the fetus. There can be a missed abortion where the fetus dies but is not aborted. Septic, recurrent, and that's generally defined as 3 or more consecutive miscarriages. Obviously you have to look at the history for that. Recurrent premature dilation of the cervix used to be called incompetent cervix, but we don't want to call anybody incompetent. So it's recurrent premature dilation of the cervix. Usually happens about 16 to 18 weeks the first time, and the cervix just opens up without pain, without contractions, and the products of conception are lost. In subsequent pregnancies, the cervix opens much earlier, so it could be 14 to 16 weeks and then 12 to 14 weeks, and that's how the diagnosis is made. Ectopic pregnancies can be anywhere outside of the uterus. Most commonly, they're in the fallopian tubes. The next slide, slide number 18, shows a speculum view of a dilated cervix, incompetent cervix, and the bulging bag of water. And the other picture shows an open cervix, and then the other one next to that is the picture of a cerclage, which is a surgical procedure where there's a stitch, a purse string stitch that's done around the cervix, and it's tied up so that the cervix cannot open. Slide number 19 is sites for ectopic pregnancies, and it's everything except the uterus, the body of the uterus. Everything from cervical to abdominal to in the tube, in various places in the tube, and even in right inside the fallopian tube. Could be ovarian. Slide number 20 shows an ectopic molar pregnancy. You can see how huge it is. It's in the fallopian tube. Another antepartum hemorrhagic disorder is the hydatidiform mole or molar pregnancies, and there are two types. You can have complete or incomplete. The complete results from the fertilization of an egg in which the nucleus has been lost or inactivated. The karyotype is 46XX or 46XY. It looks like a bunch of white grapes. They're vesicles that grow really quickly, causing the uterus to be much larger than expected for the duration of the pregnancy. So a woman who is expected to be about 12 weeks by her last menstrual period might have a fundal height of 20 or more. Contains no fetus, placenta, amniotic membranes, or fluid. Choriocarcinoma may arise from a complete mole. About 15 to 20% of women with a complete mole have evidence of persistent trophoblastic disease, not usually choriocarcinoma, but there is a small percentage that do have choriocarcinoma. And I believe we've had a discussion about a clinical patient with choriocarcinoma. The partial mole results from two sperm fertilizing an apparently normal ovum. The karyotype is 69XXY, 69XXX, or rarely 69XYY. Often they have embryonic or fetal parts and an amniotic sac. Congenital anomalies are usually present, as you can imagine, with excessive numbers of chromosomes. Clinical manifestations are vaginal bleeding occurs later, occurring in about 95% of cases. 50% of women have a fundal height more than the expected height for the gestational age. Anemia from blood loss, excessive nausea and vomiting, abdominal cramps caused by uterine distension are relatively common. Preeclampsia occurs in about 70% of women with large, rapidly growing hydatidiform moles and occurs earlier than usual in the pregnancy. So these are the ones that occur before 20 weeks. The HCG levels are very high, and the vesicles are rapidly producing. The diagnosis is made by ultrasound and a serum HCG level. The HCG levels are very high, much higher than would be expected for the gestation, and the transvaginal ultrasound shows like a snowstorm appearance on the ultrasound without any distinct fetal parts or anything. Most of these abort spontaneously, but a suction curettage or a D&C is a safe, fast, and effective method of evacuating a molar pregnancy. Induction of labor is contraindicated. Post-evacuation administration of RhoGAM for women who are Rh negative is necessary. Again, it's a termination of a pregnancy. We want to keep the mom from developing any antibodies for future pregnancies. Follow-up care. Frequent physical and pelvic examinations, weekly measurements of HCG. Monthly measurements are taken for 6 months. Follow-up assessments periods usually continues for 1 year, and pregnancy is not recommended for at least 1 year following a molar pregnancy. And this is because if the woman were to get pregnant, HCG levels would go up, and it would be difficult to distinguish between a molar pregnancy and an actual pregnancy. Could be cancer. So it's advised that they don't get pregnant for at least a year. Slide number 26 is a picture of an ultrasound picture of a molar pregnancy, and as you can see, there's not much form in there. It's pretty indistinct and looks kind of like a snowstorm. Slide number 27 shows a uterus with a molar pregnancy, both a drawing and an actual photograph. You can note the little white vesicles. Okay, late pregnancy bleeding includes placenta previa, where the placenta is implanted over the lower uterine segment, completely or partially covering the cervix. Painless bright red vaginal bleeding in the second or third trimester is its characteristic, and is diagnosed by ultrasound. Anytime a woman comes in with vaginal bleeding, vaginal exams are contraindicated, because if there's a placenta previa, you don't want to be putting your finger through it. The major complication is hemorrhage, obviously from a placenta previa. Another complication is the development of an abnormal placental attachment, such as a placenta accreta, placenta increta, or placenta percreta. The accreta is a slight penetration of the myometrium instead of just a decidua basalis. The increta, there's actual deep penetration into the myometrium, and placenta percreta is the perforation of the uterus by the placenta. It actually extends through the uterine wall into adjoining structures such as the bladder. And this causes the inability of the placenta to be detached after delivery, sometimes necessitating a hysterectomy. For management of this, it's got to be a C-section, obviously, because of the if the placenta is delivered first, the baby will be compromised and quite possibly will die. No vaginal exams, and then again ROGAM if necessary. Slide number 31 shows a placenta previa compared to a normal. The normal is anterior fundal placenta up in the top, and the placenta previa is down covering the cervix. There can be a marginal previa. Slide 32 shows a normal versus placenta previa. Normal placenta, again, is fundal. There's a marginal with the edge of the placenta down near the cervix. Partial placenta previa, it's part of the placenta is covering the cervical os, and then a complete previa is covering the cervical os completely. With marginals and partials, they may be able to deliver vaginally because as the fetal head comes down, it will tamponade off the bleeding as the cervix dilates, but that would be up to the physician. Depends on the number of the amount of bleeding that's going on at the time. The next condition is abruptio placenta, or premature separation of the placenta before delivery of the fetus. It's a normally implanted placenta, but for several reasons it can become detached. It occurs in the area of the decidua basalis after 20 weeks, but before birth of the infant. It's a serious complication that accounts for a significant maternal and fetal morbidity and mortality. Maternal hypertension is the most consistently identified risk factors, and cocaine use is also a risk factor. It causes vascular disruption of the placental bed, so it's also used to be seen quite frequently in cocaine addicts. Slide number 34 is a picture of a uterus with a fetus and a placenta with a retroplacental hemorrhage, or a hemorrhage between the placenta and the uterine wall. 35, slide 35 is an ultrasound picture of a placental abruption, and the arrows indicate where that is. Other risk factors for abruption include cigarette smoking, history of an abruption, preterm prolonged rupture of membranes, presence of inherited or acquired thrombophilias, and probably more commonly seen is a blunt external trauma such as a motor vehicle accident or maternal battering, domestic violence. Classic symptoms are vaginal bleeding and abdominal pain. The uterus is very tender, and there may or may not be contractions, but it's very tender. Pain is mild to severe, localized over one region, or diffuse over the entire uterus with a board-like abdomen. Painful, bleeding, board-like abdomen are classic for abruption, whereas painless, bright red bleeding is hallmark for the placenta previa. Management of an abruption. Immediate birth is the management of choice if the fetus is at term or if the bleeding is moderate to severe and the fetus or mother are in jeopardy. Need a large bore IV line, sometimes two. Frequent maternal vital signs, probably in some cases as often as every 5 minutes. Serial lab studies such as H&H. An indwelling urinary catheter is inserted to measure maternal organ perfusion. And blood and fluid volume replacement may be necessary. Packed cells, fresh plasma, albumin, or just IV fluids. End of part 1.